And good evening, everyone. And I'm going to talk about the role of sentinel node biopsy in oral cancer. Now, we all know that elective neck dissection is a standard of care today, as shown by a study from our institute. And we know that elective neck dissection improves overall survival by 12.5% and reduces the risk of death by 36%. And one death is prevented for every 8 neck dissections performed. And similarly, the disease-free survival improves by 23.6% with the elective neck dissection, and the risk of recurrence is decreased by 55%. And for 4 neck dissections, one recurrence is prevented. But also known as the fact that 55 to 70% of the patients are node negative and they don't have a nodal metastasis, and therefore they do not require a neck dissection. And also we know that neck dissection has its own morbidity, predominantly in terms of nerve dysfunction that can be seen in about 35 to crippling also in about 5% of the patient. The debate of wait and watch and elective neck dissection is more than 5 decades old. While this debate was continuing, people were also looking out for the option if there can be something in between the two. And after the elective neck dissection became the standard of care, again, there was a need for the option that could circumvent the morbidity of the neck dissection and identify the true node negative cancers. So that is why the sentinel node biopsy was being explored in oral cancer for more than a decade now. Now, what is a sentinel node? The concept is that sentinel node is defined as a lymph node on a direct drainage pathway from the primary tumor. Now, it is a lymph flow from the primary tumor that first goes to the sentinel node and then to the other regional lymph nodes. Now, that means that if from the primary tumor, it is not going to the sentinel lymph node, or not going means the metastasis has not gone to the sentinel lymph node, that is the sentinel lymph node is negative. In all probability, that is a true node negative neck, and probably the neck dissection can be spared in this set of patients. Multiple options have been explored to identify the sentinel lymph node. The gold standard today is a conventional lymphoscintigraphy followed by the SPECT. And in this, it is the technetium labeled sulfur colloid or technetium labeled nanocolloid is injected, which emits gamma rays. And then these gamma rays are detected and are used to identify the sentinel lymph nodes. Apart from that, multiple options being explored, MR lymphography, CT lymphography, PET lymphoscintigraphy, but they're all in the experimental stages. Now, the diagnostic accuracy of the sentinel node biopsy has been known for more than 2 decades now. This is just a list of various meta-analysis that talk about the diagnostic accuracy. And we all have known that the diagnostic, the negative predictive value of the sentinel node biopsy is to the tune of 95 to 96%. And therefore, it is very, very safe to spare the neck if the sentinel lymph node biopsy is negative. But what was not known over this time was whether it is oncologically safe or not. And this evidence for the first time was provided by the SENT trial when they reported their 3 years outcomes in the sentinel node biopsy, sparing the neck in the patients where the sentinel node was negative. So this was 415 patients with T1, T2 lateralized oral squamous cell carcinoma. And in this study, the authors showed that sentinel node was identified in 99.5% of the cases. The sentinel node was metastatic in 23% of the cases, and a false negative rate was about 14% in this study. And there were very minor complications reported with the sentinel node biopsy, which was seen only in 3% of the patient. The disease-specific survival was 94%, and again, the sensitivity of the sentinel node biopsy was 86%, and negative predictive value 95%, as we had always known. So this was the first time the 3 years disease-specific survival was reported, and that is when we came to know, yes, it is oncologically probably a safe option. But again, what was lacking in the literature was a head-on comparison with the elective neck dissection, which is a gold standard in this cohort of patient. And so the 2 trials were published in JCO towards the end of 2020 and the beginning of 2021. So this is the French trial, which was an equivalence randomized control trial, which compared the sentinel node biopsy versus elective neck dissection in T1, T2, N0 oral and oropharyngeal cancer. SENTI-MARORAL trial. This was a multicentric randomized open label trial. In this 279 patients were analyzed. And authors assessed the oncologic equivalence of sentinel node biopsy and neck dissection and compared the 2 years neck node recurrence-free survival as the primary endpoint. So this is the trial schema. T1, T2, N0 oral and oropharyngeal cancers. They were allocated in the ratio of 1:1 to sentinel node biopsy or elective neck dissection arm. In the sentinel node biopsy, routine frozen section was performed, and if the node was reported as metastatic, a completion neck dissection was performed in the same setting. And if the sentinel node was reported as negative, in those cases, a serial step sectioning and immunohistochemistry was performed. And again, if the node was reported as positive, a second stage completion neck dissection was performed. Otherwise, the patients were observed. In terms of the primary endpoint, the 2 years neck node recurrence-free survival, the outcomes were comparable, as we can see completely intertwining curves. 5-year neck node recurrence-free survival were also similar in the two arms. And the difference between the arm in the 2 years neck node recurrence-free survival was 1.1%, which was much lower than the 10% hypothesis. And therefore, the non-inferiority or the equivalence, according to the authors, equivalence of the sentinel node was established in comparison to the elective neck dissection arm. The authors also reported the functional outcome in this cohort of patient, and we can see this is a red dot plot. This is computed at various time points of 2, 4, 6, and 12 months. The solid line depicts the elective neck dissection. The dotted line depicts the sentinel node biopsy. And we can see that as initially there is a significant difference between the two curves, but as the time passes by, the curves start to overlap. So there is a limitation of the morbidity with the sentinel node biopsy, but the elective neck dissection also recovers, and at the end of 12 months, we see quite overlapping curves. The median hospital stay was around 8 days with a range of 2 to 94 days in the neck dissection arm, and it was 7 days with a range of 3 to 30 days in the sentinel node arm. And this difference was statistically significant. We notice it's a mere difference of 1 day, but if we look at the range, we see a significant difference with upper limit being 30 for the sentinel node arm and 94 being for the elective neck dissection arm. As I already explained, the functional outcomes were significantly worse in the neck dissection arm until the end of 6 months after surgery. And the number of prescriptions for the physiotherapy were higher in the neck dissection arm compared to the sentinel node arm. And lesser number of the patient could perform the arm abduction, that is overhead abduction above 180 degree in the neck dissection arm compared to the sentinel node arm. Up to the 12 months, the score of the self-reported questionnaire was significantly different between the two arms, but there was absolutely no difference at the end of 24 months. So there is a morbidity which is significantly limited by sentinel node biopsy. However, with the time, the function of a neck dissection also recovers. This is another trial. This is a Japanese trial, and it was published in JCO in 2021. This is a non-inferiority trial. It's a multicentric randomized control trial involving 16 Japanese centers. And in this, a sentinel node biopsy navigated neck dissection was compared with the elective neck dissection in the tumor category of T1, T2, N0 oral squamous cell carcinoma. And in this, the authors chose to have tumor of more than 4 millimeter depth of invasion, where they thought that this is a cohort which is associated with the higher rates of occult metastasis and probably the relevant cohort. Now, the only difference was in this, the schema is absolutely similar as I discussed before. The only difference being that these were only oral cancers and previous were oral and oropharyngeal cancers. At the median follow-up of 3.1 years, 271 patients were analyzed. And again, we see completely overlapping curves. So in the sentinel, the primary endpoint was overall survival. And here we see that in the sentinel node group, the 3-year overall survival was 87.9% compared to 86.6% in the neck dissection arm. And this was non-inferior according to the assumption where they had taken a wide range of 12% being non-inferior. The functional assessment again was done in this. Hello. Okay. If someone wants to ask a question, we can go ahead with the question, but otherwise I would request whoever is prompting to mute themselves if there is no question. So functional assessment of the neck was done based on the quality of life scores and arm abduction test. And again, it was significantly better in the sentinel lymph node group compared to the neck dissection group. Now, this is a meta-analysis that was conducted at Tata Memorial Hospital based on these two trials. And there was extraction of the individual level participant data from the Kaplan-Meier curve. And here we see a cohort of 550 patients now, and again, completely overlapping curves, establishing the oncologic safety of sentinel node biopsy vis-a-vis elective neck dissection. So this is a summary of the three important trials in the sentinel node biopsy. And one thing is consistent, that it has a very good identification rate ranging from about 94 to 99.5%. False negative rate ranging somewhere between 14 to 15.4%. And the frozen section that is being used, but there is a heterogeneity in the type of a frozen section that is being performed, and also heterogeneity regarding the histopathology that is being performed. And we see that there is a lack of consensus when it comes to the isolated tumor cells. These are very, very small cells of 200 microns, and these were considered negative in the French trial and positive in the other two trial. So there is a debate what to do with these, and French trial observed, while rest of the two trials performed the completion neck dissection. So with all this evidence, we see that there is a change in the management of the neck in a node-negative early oral cancer. And today we see that we have both the options there. We can do an elective neck dissection, and also equally viable option is to do a sentinel lymph node biopsy in this cohort of patient. These are the simple steps as we do a sentinel lymph node biopsy. So here we see the nanocolloid being injected. So this is one of the cases that we have done at Tata Memorial Hospital. And this is a planar imaging being performed, and we see the emergence of the sentinel lymph node here. We do a SPECT scan, and then we confirm the location of the node, as we can see here with respect to the landmark structures. Like here we can see the sternocleidomastoid muscle, the hyoid bone. So we know where the node is. And then intraoperatively, it is localized with a handheld gamma probe, and this node is dissected out and subjected to frozen section and then to the histopath. Now, we have done more than 100 sentinel lymph node biopsy at Tata Memorial Center. This is the abstract that was submitted for AHNS presentation in 2023. And this was the initial analysis of 60 patients, and this exercise was done to standardize the sentinel lymph node biopsy procedure in oral cancer with node-negative neck. And a primary objective for this study was to assess the diagnostic accuracy of sentinel lymph node biopsy in this cohort of patients. We also did the 2 mm block for the frozen section. So we also wanted to assess if extensive frozen section with 2 mm block can afford the second procedure. So the patients were all more than 18 years of age, biopsy proven squamous cell carcinoma, T1, T2, according to the AJCC 8th edition, clinico-radiologically node-negative neck, all could be excised perorally, and treatment naive cases were taken on this study. This is a retrospective analysis of a prospectively maintained database of all the sentinel lymph node biopsy that we performed from 1st June 2021 to 15 November 2022. And in all these cases, the sentinel lymph node biopsy was followed by completion neck dissection. We used the nanocolloid injection for the localization, and SPECT was performed in all the cases. And if any point in time the node was not detected on the planar imaging or SPECT, and also with the handheld gamma probe intraoperatively, at that time we believe that it basically we performed the surgery on the same day after within the 6 hours of localization of the sentinel node, and we use a dual dye technique. So one was a nanocolloid, and we also use an optical tracer which could either be methylene blue or indocyanine green. And then these nodes were subjected to the frozen section. And this was the extensive frozen section at 2 to 3 millimeter blocks. And minimum of 2 sections, one was stained with toluidine blue and other with hematoxylin and eosine. And this is how the frozen were evaluated. And eventually we performed the histopathological processing. So this is just to tell through the figure. If it's a elongated node, the blocks of 2 to 3 millimeter were performed. If it was a bigger node, it was first bisected and then these blocks were performed. And again, as I explained before, toluidine blue and hematoxylin and eosine staining was done. Now, if this node was reported as positive in the frozen section, we did the completion neck dissection, and if it was negative in those cases, we further processed it and again got it reported. And if it was reported, because we did the completion in the same sitting, so that is why we did not perform any second stage completion neck dissection. Now, in this, out of 60 patients, 2 were taken out of the analysis because in one patient, the completion neck dissection was not performed. And in the other patient, there was also a synchronous primary in the thyroid with a papillary thyroid cancer that was detected on the frozen section. So majority were males, which were about 50 cases, tongue predominantly 53 cases out of 58. And the higher number of cases were T2, that is 33 out of 58. In all the cases, we use methylene blue except for 3, where we use indocyanine green. And in one patient, we just performed the nanocolloid and no optical tracer was used. The occult metastasis was detected in 22.4% of the patients. Majority of the nodes were ipsilateral as expected, but we had a bilateral representation in also about 7% of the cases. We had isolated contralateral seen in about 3.4% of the cases, and we were unable to localize the node in 1.7% of the cases. Frozen section was performed in 56 patients out of 58, and in 2 it was not performed, and we could identify the sentinel lymph node in 57 out of 58 patients, which is 98.3%. In the histopathology, the sentinel node was reported as metastatic in 11 cases, and in 2 cases where the sentinel node was reported as negative, we could find the metastasis at other levels. So our false negative rate was 15.4%. The sensitivity was 84.6%, specificity was 100%, negative predictive value was 96%, and positive predictive value was 100%. When looking at the outcomes of the frozen section, excluding the 2 where we did not perform the frozen section identified metastatic nodes in 10 cases out of 13, and therefore the sensitivity of frozen section was 75%, and the negative predictive value was 93.6%. So our experience suggests that it is a feasible procedure at a high volume center. A second procedure can be avoided in the majority of the cases through an intensive frozen section, and time to node localization is substantially reduced if we are using the nanocolloid, and outcomes are at par with the results that are reported in literature. Despite this evidence, we know that sentinel lymph node biopsy has limitation. There is a need for the infrastructure. It is a 2-stage procedure. In nearly 10% of the patient will need second surgery. It has a very intensive, labor-intensive pathology protocol, and a significant number of ITCs are detected, and we are unclear what to do with these ITCs. And there is limited applicability in the resource-constrained setting and at a very high-volume center. So this is just to show the occult positivity rate from the 3 trials and the number of patients requiring the second surgery. Here we can see. So significant number of patients require second stage surgery. So therefore, there is a need to optimize the guidelines with context to the isolated tumor cells. And we should extrapolate what we have learned from the other sides to the oral cavity. And with this, we also thought of that there could be a very conceptually attractive option of sparing level 2B and 5, and so that the nerve morbidity is limited in the elective neck dissection. So with this, we proposed a trial which was a sentinel node biopsy versus limited elective neck dissection in early cancers of oral cavity node negative, second N0 trial. And this is a non-inferiority phase 3 trial, T1, T2 oral squamous cell carcinoma, clinico-radiologically negative. So the target sample that we have calculated is 508 patients. And these patients will be stratified by the site, that is tongue versus buccal mucosa, and a T stage, T1 versus T2, and they will be randomized in the ratio of 1:1 to the 2 arms. This is a trial schema, by and large similar to all other trials, and only that in limited neck dissection, we are going to perform a frozen section for a level 2A. And we are going to clear 2B only if this 2A is metastatic, otherwise we are going to spare 2B. And we are going to clear out levels 1, 2A, 3, or 4, depending upon the operating surgeons. The aim of the study is to compare the survival outcome, morbidity, and cost effectiveness of sentinel lymph node biopsy vis-a-vis limited elective neck dissection. The primary objective is the overall survival. Secondary objective is the shoulder morbidity, which will be measured longitudinally up to 2 years, disease-free survival, neck node recurrence-free survival, and we're also going to look at the side effects of the elective neck dissection like chyle leak, hematoma, and lymphedema, and longitudinal follow-up for the quality of life and cost-effective analysis. So we will be able to answer another crucial question: if we can have a suitable alternative for the sentinel lymph node biopsy and just little tweak in the elective neck dissection, and we can still go ahead with the same. But till that time, what does the evidence tells us? It tells us that sentinel lymph node biopsy is non-inferior to elective neck dissection in terms of oncologic outcomes. Sentinel lymph node limits the morbidity, which evens out at the end of 1 year. Limitations, however, restrict the wide spread applicability. This is just a 4 minutes video. I hope the time permits, so I can just quickly show to the youngsters the steps of the sentinel node biopsy. So this is, Asim, is it okay?
Yes, ma'am, please continue. No issues.
Okay.
We have time.
Okay. Yeah, so we just saw a lateralized tongue lesion. So this is technetium labeled human serum albumin, that is a nanocolloid, and this is an injection which is being done around the tumor. This is a dynamic lymphoscintigraphy, which is being done. Usually we do it for 30 minutes, but the node emerges somewhere between 2 to 15 minutes. So this is the emergence of the sentinel node, as we can see. Once we see the node, we do the SPECT immediately. The whole procedure takes around 30 to 40 minutes. So this is the light up of the primary. And here we see the node. So we can see with context to hyoid, submandibular gland, the sternocleidomastoid muscle. So this gives us the idea where the node is. We usually inject methylene blue. The advantage is once we open the plane, of course, with the gamma probe, you identify, but it is also very quickly visualized. So similar tuberculin or the insulin syringe being used, and we are injecting the methylene blue in the same 4 quadrants where we had injected nanocolloid, avoiding the spillage. And after excising the primary, we are marking the landmarks in the neck. And after confirming the position with the probe, this is handheld gamma probe, angled handheld gamma probe. Now we have identified the position. According to it, we are marking the skin incision from which we can even do the neck dissection if the need arises. So it's a small incision, smaller than the neck dissection because it's just a node biopsy, and we should refrain from opening extra planes and larger incision because if we have to go back again, we don't want fibrosis. Opening up a subplatysmal plane slightly. With the handheld gamma probe, we are confirming the location. You can see that it is an angled probe and we are keeping the angle away from the floor of mouth because otherwise it will interfere with the activity. So after the node localization with the probe, a dissection is performed with the help of mosquito. It's a small incision. So as we open the plane, we can see a bluish or a dark blue hue because of the methylene blue that we have given. So we are 100% sure because our gamma probe showed this as a node, and also with the blue color, we know this is the node. And with the SPECT location also, according to it only we have opened this plane. The adequate lymph node, say sentinel lymph node biopsy should harvest 2 to 3 nodes at least. And here we see 2 together. So after we have excised it, the activity should be confirmed with the handheld gamma probe to ensure that we have taken out the right node. We can see it's blue in color and it is hot. It's showing the activity. So any activity which is 10 times the background is considered as significant. After confirming the activity, go back to the basin and confirm that there is no residual activity. And usually the basin activity would be merging with the background activity. Confirm at other levels if there is any other sentinel lymph node. So all along the neck with the handheld gamma probes, meticulous detection of the activity, and then this node is subjected to the frozen section, and then accordingly we proceed. That's it. Thank you so much. If there are any questions, I'll be happy to take. Or otherwise, we can proceed to case presentation.
So, ma'am, we'll proceed with the case presentation. And but before we proceed, I'll just
Yes.
want to invite everyone on Mahamana Oral Oncology update that is to be held on 10th of February 2024. That is day after tomorrow. And we also have all the interesting sessions. So I'll request that please join, and I have shared the registration link. It is a hybrid conference. 20 participants are allowed in-house and the remaining can attend from online. So all of you are welcome there. Komal, you can please proceed.
Thank you, Richa ma'am, for such a wonderful presentation. And now we move on to the case presentation. For case presentation today, we have with us Dr. Rukmini Prabhu. Dr. Rukmini is a resident at Tata Memorial Hospital in the Department of Head Neck Surgical Oncology. She'll be presenting the case. And for the moderators of the case presentation, we have Dr. Arvind Krishnamurthy. Sir is professor at Adyar, sir is professor in surgical oncology at Adyar Cancer Institute, Chennai. Welcome, sir.
Thank you. Thank you.
Welcome, sir. Next, we have Dr. Amitabh Ray. Dr. Amitabh is Associate Professor in the Department of Radiation Oncology at CNCI, Newtown, Kolkata. Welcome, sir.
Thank you so much for inviting me. Good evening, everybody.
And then we have Dr. Anuj Kumar. Dr. Anuj is Assistant Professor, Department of Radiation Oncology, ACTREC, Navi Mumbai. Welcome, Dr. Anuj.
Thank you for the invitation.
So now we can proceed to the case presentation. Dr. Rukmini, over to you.
Am I audible?
Yes, you are. Switch on the video.
So coming to my presentation, my patient is a 50-year-old gentleman, a resident of Mumbai, a mechanic by occupation, who presented to our OPD with chief complaints of a non-healing ulcer on the right side of the tongue since 4 months. Coming to the history of presenting illness, the patient was asymptomatic 4 months ago when he noticed an ulcer over the right side of his tongue, which was insidious in onset. It was initially small in size and has gradually progressed over a period of 4 months to attain the present size. It is associated with pain, which is dull aching type, which is not radiating, which is aggravated on chewing, and it is relieved with painkillers. He also gives history of excessive salivation. He does not give any history of difficulty in speech or swallowing. There's no history of any change in voice. There is no history of decreased mouth opening. There's no history of any bleeding from the lesion. There is no history of any loose teeth. There's no history of any neck swelling. There's no history of any other ulcer or mass anywhere else in the oral cavity. He is a chronic tobacco chewer, chewing gutka around 2 packets per day since the past 25 years, and he has stopped since the past 3 months. He has no history of smoking tobacco, no history of alcohol consumption, no history of dentures or any sharp teeth. He does not give any history of weight loss. There's no history of difficulty in breathing, cough, bloodstained sputum, bone pain, or chest pain. He has not taken any treatment elsewhere for the present complaints. Coming to his past history, he's a known case of hypertension on medication since 3 years. There is no history of, he does not give any history of diabetes, cardiac disorders, thyroid disorders, or any surgeries in the past. There is no significant family history. To summarize, my patient is a 50-year-old gentleman, a known hypertensive, chronic tobacco chewer with a 4-month history of a non-healing ulcer on the right side of the tongue that is associated with pain. Should I proceed?
Yeah, go ahead.
Coming to the examination, on general physical examination, his performance status is ECOG 0. He is conscious, cooperative, and oriented to time, place, and person. He is well built and nourished. He was afebrile. His pulse rate was 84 beats per minute in the right radial artery. The blood pressure was 120/70 in the right arm sitting position. The respiratory rate was 20 cycles per minute. There was no pallor, icterus, cyanosis, clubbing, generalized edema, or generalized lymphadenopathy. On local examination, his mouth opening was 4-finger breadth. he is dentate. His teeth were tobacco stained. The tongue movements were normal. There was a single ulcer of about 2.5 cross 1.5 on the right lateral border of the tongue at the level of the lower first and the second molars. On inspection, it had everted edges anteriorly around 2 centimeters away from the tip. The floor of the mouth was free. Posteriorly, the circumvallate papillae, the anterior pillar, tonsils, base of tongue, RMT were free. It is away from the midline. No other lesions were seen in the oral cavity. On palpation, my inspectory findings were confirmed. The induration is away from the midline. There are no any loose teeth, and there was no other lesion palpable in the oral cavity. The oropharynx is within normal limits on inspection, and there was no induration on the base of tongue. On Hopkins, bilateral vocal cords were mobile, and there were no suspicious lesions seen. On examination of the neck, there were no scars, sinuses, or dilated veins. The skin of the neck is normal, and there were no palpable nodes. The systemic examination was within normal limits. So to summarize, my patient is a 50-year-old gentleman, a known hypertensive chronic tobacco chewer with a 2.5 centimeter non-healing ulcer on the right lateral border of the tongue, not crossing the midline, not involving the base of tongue or the floor of mouth, with no palpable neck nodes. So most likely a malignant neoplasm of the right lateral border of the tongue. If so, clinically T2N0.
You have a dental formula to tell, or the dentition, anything? Any missing teeth? Did you mention it? Or?
No, sir. No, sir. He is dentate. There were no missing teeth, sir.
Yeah, I think you sort of mentioned about sometimes they have a formula, right? So better to sort of mention that in your okay. There was
Okay.
no. And 4 finger breadths, can you better qualify, or how do you sort of measure?
Technically, we should be using calipers to measure the mouth opening, sir.
Yeah. So so any other objective method, are you aware, or to measure the mouth opening? Because finger breadth is very subjective, right?
So, using a caliper, sir, the distance with the interincisor distance is measured, sir.
So, but do you normally do that in clinical practice or anything else? Yeah, you're right. I think it's an incisor distance only, but
in clinical practice, we use like the 4 finger breadths is the patient's fingers, the number of patient's fingers that can be inserted in between the 2 teeth, sir.
Right. I think it's better to sort of maybe a scale or something. I don't know what's the practice normally, like but better to sort of mention some objective parameters in terms of because there is a classification, right? You're aware of the classification of interincisor distance, right?
Oh yes, sir.
Yeah.
So more than 35 mm, then grade 3 is between 26 to 35 mm, then between 15 mm to 25 mm, and less than 15 mm, sir, mouth opening.
Correct. Yeah, I think just to, it's a statement that you tell the examiner that you're aware of this, right? So I guess you can possibly substantiate your finger breadth with with the distance as well, like interincisor distance as well.
Yes, sir.
Interrupt for a moment. Richa ma'am, if you're there, can I request you to be one of the moderators?
Rukmini, I had a question. So,
Yes, sir.
can you approximately measure the depth of invasion clinically? Because this is a tongue tumor, and clinically, if you measure the depth of invasion and get an approximate idea, will it have an implication on the staging also?
In a tongue lesion, it is difficult to clinically measure the depth of invasion, sir. In a buccal mucosa, it is.
At least you can palpate approximate thickness, because if it is a thickish tumor, now you have told that it is not crossing to the midline, so I don't think it is going to be a thickish tumor. But still,
Yes,
I
sir.
think you will have an approximate idea when you palpate clinically. roughly, I'm not telling, the more objective method will be an MRI only in the clinical setting, but still, I think you can give an approximate idea.
Sorry to interrupt. Richa ma'am, are you there?
Yes, Komal, I'm there. I'll chip in, don't worry. I'll just ask the next question maybe.
Yeah, thank you, ma'am.
No, but why do you say tongue is difficult? No, it's easier. No, you are able to digitally or manually palpate the entire lesion, right?
Yes, sir. As compared to the buccal mucosa, I meant, sir, like it's
Yeah, buccal
we can
mucosa
palpate
are
in
the
the
same
tongue.
thing, right? So tongue and buccal
Yes, sir.
mucosa, which are the
Bidigitally, yes.
yeah. So it's actually the other subsites that will be difficult to sort of palpate, right?
Yes, sir.
Yes, I remember.
Yeah. So tongue and buccal mucosa may be relatively slightly easier in a way, like that's what they say. But did you make an attempt? You said some induration.
Yes, sir. The induration on the tongue is palpated and it is away from the midline, sir.
Away means I didn't get you one.
It is around 1 centimeter away from the midline, sir. The induration on the tongue
Away means to the other side, to the
towards the lesion, sir.
towards the lesion. So yeah, okay,
Yes.
okay. Right. Yeah, okay. Any other questions? Anybody? Yeah. Okay. Good.
Fine, that's okay, Rukmini. So what is your clinical impression at the end of the history and the clinical examination?
At the end of the history and clinical examination, the provisional diagnosis would be a malignant neoplasm of the right lateral border of the tongue, clinically a T2N0, ma'am.
T2N0, and this you were saying because of the surface dimensions being 2.5.
Yes, ma'am.
That is what you were saying is
Yes.
largest.
Yes, ma'am.
Okay, so how would you investigate this patient?
I would like to get a biopsy done, cross-sectional imaging, a metastatic workup, and routine investigations, ma'am.
Okay, I think I just missed a part of the history. Was there any pain associated with the swelling or the
Yes,
lesion?
ma'am. Yes, ma'am. He has history of pain, ma'am.
Pain localized or referred pain?
No, pain localized, not radiating or referring to the ear, ma'am.
And why do you get the referred pain?
Because of the shared nerve supply between the tongue and the ear, ma'am. The lingual nerve supplies the tongue, and which is a branch of the mandibular nerve, and also the auriculotemporal nerve supplies the ear. So because both are from the trigeminal nerve, there is cortical misinterpretation as the pain which is from the tongue being from the ear, ma'am. So that is why there is refertotalgia, ma'am.
Okay. Okay, so go ahead now. You were telling about the investigation that you're going to do.
I would get a cross-sectional imaging done, ma'am. I would get an MRI, contrast-enhanced MRI in this case, a biopsy, and a metastatic workup.
Okay. Why do you want to do a cross-sectional imaging in this case? It's the early tongue. You said it is quite thin, although I missed that part. But anyway, it looks like it's a T2. So why do you want to do the MRI? What additional information will you get with the MRI?
We will also get information on the status of the neck nodes, ma'am, by doing a cross-sectional image. Imaging, doing an MRI will give us information on the primary as well as the neck nodes, ma'am, as opposed to doing only an ultrasound to assess the neck nodes.
Can you describe it in more detail, Rukmini, like MRI to assess how will it help you locally as well as regionally, little bit in detail?
So it will help us to assess the extent of the disease. It will help us to see if there is any perineural invasion, to assess the depth of invasion on the MRI. And it will also help us to assess the involvement of the neck nodes.
Okay. The
Why not
neurovascular
PET CT?
Sir, as per
You can choose
evidence,
not, you can choose to disagree as well, or agree, or give any evidence also, right?
sir, as per the meta-analysis done by Liao et al. Comparing ultrasound, CT scan, MRI, and PET CT, there was no difference in the sensitivity or specificity between all these modalities. So, doing a PET CT for all the
That was in
metastatic workup and for
2012.
the
No?
prime. Yes, sir.
What is in 2024? Any, okay, anyway, you can tell many more evidences that you tell. I mean, you can choose to disagree also. I'm just asking you.
According to the meta-analysis done by Liao et al. And D. Bont, the sensitivity and specificity is good enough with a CT or an MRI, sir. And PET CT would be an expensive investigation.
Any more investigations, any more evidence, any more recent evidence
I don't know, sir.
that anybody else has got any?
Dr. Rukmini, if I may ask you,
Yes,
what
sir.
if an MRI is contraindicated in your patient due to some reason? What investigations would you then suggest?
A contrast enhanced CT scan, sir.
And what would be the extent of the scan that you would ask for?
From the contrast enhanced CT scan of the head and neck, sir. For the metastatic workup, to image the lungs, we could do a non-contrast CT scan also, sir.
Rukmini, how common is the distant metastasis in T1, T2, N0 tongue? You would do a distant metastatic workup in all these patients?
No, ma'am.
So instead of getting a CT scan, NCCT
Get a
thorax
chest.
little cold, in T1 and T2,
We could
why
get a
can't
chest
you
X-ray.
just get a chest X-ray done
Chest
that will
X-ray.
assess the fitness for surgery or any other
Yes,
investigation? Why can't you only get a chest X-ray done for a T1 or T2?
we could get the chest X-ray done, sir.
Okay, so what you have done the biopsy for this patient? You have
Yes,
the
ma'am.
investigation?
Yes, ma'am. The biopsy is a moderately differentiated squamous cell carcinoma, ma'am.
Okay, and you did a CT thorax. NCCT or CECT?
NCCT, ma'am.
Why do you do NCCT? Why not CECT?
NCCT thorax is good enough to pick up the distally located. If the metastases are present distally, they are good enough to pick up the metastasis as opposed to a contrast enhanced CT thorax, ma'am.
That's the reason.
Yeah, is that the reason, or what is the additional advantage if you give a contrast? What else will you be able to see? Your answer is correct. NCCT thorax is enough for evaluation of pulmonary nodules, but it is not that it is seen better. So when you give contrast, is there anything else you will get a benefit?
Second primary.
Mediastinal nodes, if this is not relevant to this case, but a contrast can actually pick up mediastinal nodes better for pulmonary nodules. NCCT thorax alone is sufficient.
Yes, sir.
Yeah, because it acts as a natural contrast when there is air in the lungs. So there's a natural contrast and you can see this metastasis, and that is why it's okay. But if you're looking at the mediastinal structures and pertaining to the blood vessels, then of course you have to give the contrast. But in this case, NCCT is okay.
Yes.
Okay, do you have the MRI images
Yes.
available?
It's not playing, Rukmini.
1 second, sir.
Yeah, no, it's fine.
Yeah, it is playing, Rukmini, but you have to explain with it as it goes. What sequence? What are we looking at? Where is a lesion? Where is a node?
This is a MRI with contrast, T1 weighted fat suppressed sequence, and on this we can see a lesion, enhancing lesion on the right lateral border of the tongue. It is of a size 3 centimeters, and we can also see a right level 2 node is with necrosis.
Where is a node?
One
Keep your
second.
pointer on the node.
This one. This.
Okay. So now your clinical radiological stage is?
T2 N1. Depth of invasion is 8 mm, ma'am.
What is the
On the MRI
difference?
report,
What is the difference in the between depth of invasion and tumor thickness?
depth of invasion is the distance between the basement membrane and the deepest point of invasion of the tumor, whereas tumor thickness is the distance between the maximum proliferative surface of the tumor till the deepest point of invasion, ma'am. So to measure the depth of invasion, a plumb line is dropped from the basement membrane, ma'am.
So can you measure the depth of invasion on MRI?
Yes, ma'am.
How?
From the
You are saying, no?
yes, ma'am.
Hmm.
It's actually tumor thickness, ma'am. Depth of invasion is measured on histopathology.
So then 8 mm, what you are reporting to us is the tumor thickness or the depth of invasion?
It will be the tumor thickness, ma'am.
So we just cannot measure any depth of invasion on MRI. So it may not be as accurate as this, but at least we take it from the adjacent normal mucosal surface that we see.
Yes.
So obviously it will be 100% accurate, but it gives us some idea.
Yes, ma'am.
Yeah, and Rukmini, also depth of invasion, it can be only measured in histology because it is in the clinical staging, right? Because in the
Yes.
clinical staging, if it mentions depth of invasion, we can't tell it will be measured only in histology. Okay, it will be
Yes.
more accurate in histology, but also you can measure by radiology and clinical.
Yes, sir.
So what will you do next?
Since this is a carcinoma tongue right lateral border T2 N1 with M0, I would like to proceed with surgery for this patient, ma'am. I would consult the patient for surgery for this patient, ma'am. So for the surgery, I would like to do a right lateral border tongue wide excision with a right selective with a right neck dissection levels 1 to 5 and primary closure or maybe an SOS local flap, ma'am.
Why surgery? Why not some other modality?
As per evidence, according to the paper by Robertson et al., surgery should be the primary modality of treatment for oral cavity cancer. And in their study, 16 out of the 18 patients who were on the radiotherapy arm died. So surgery prevents mortality in oral cavity cancer. So the primary modality of treatment should be surgery, ma'am. Also, in the paper by Gopal Krishna Iyer, in which they included all head neck cancer patients, they also concluded that surgery should be the primary modality of treatment for oral cavity cancer.
Okay. And how do you decide the reconstruction plan for tongue? What are the options?
Depending on the extent of the resection, ma'am. If it is a wide excision or a hemiglossectomy, we could opt for a local flap or a free flap. If it is a more extensive resection like an anterior two-third glossectomy or a near total glossectomy, then we could have we will have to choose between pedicled flaps like the PMMC or a free flap, ma'am.
And when do you leave it raw or you close primarily?
If less than 1/3 of the gross surface of the tongue is excised, ma'am.
And what will be your extent of neck dissection in this case?
In this case, since he has a positive level 2 neck node, I would like to go ahead with a modified neck dissection with neck dissections of level 1 to 5, ma'am.
Okay.
Rukmini, you told surgery is the ideal treatment of choice. What if a radiation oncologist in your institute tells that this is an early cancer? And if it is, see, this is a T2, if it is a T1 N0 tongue, if they tell they will do brachytherapy for this lesion, how will you answer that? Like, why will you consider surgery over brachytherapy in a T1 N0 or a T2 N0 tongue? Can you tell your points to justify?
So those papers are
like you told, yeah, you have told quoted papers, but you should also see the group of patients who were included. You mentioned about Gopalakrishna Iyer's papers, but that is on locally advanced head and neck cancers, right? So I don't think we are now talking about early oral cancers. And in early oral cancers, brachytherapy has a role. I'm not telling specifically with tongue. But for example, if it was a lip T1 N0, you have a role of radiotherapy there, right? So that's why, like, if someone tells they can do a brachytherapy, will you accept that? Or I just wanted to ask you, how will you tell that you will go for surgery for this patient?
Rukmini, just what rationale behind choosing surgery? Not the evidence. Give the rationale, the points in favor of surgery.
Yeah, exactly.
We have to address the neck also, ma'am. So
yeah, good. That is one of the.
There's one point.
Yeah, good.
Other points? Why would you not consider this patient for brachytherapy? Suppose it was T1, T2, N0. Would you have considered this patient for brachy then?
no, ma'am.
Why not? Tongue is a mobile organ.
Yes, ma'am.
So it may be difficult.
It may be difficult to. Okay, yes, ma'am.
Then surgery is easy. You can do it in one sitting.
Yes, ma'am. Okay.
Yeah, like that. So it is not only the evidence, you should know the rationale also, why we are doing this.
Yes, ma'am.
And why do we choose brachytherapy in the cases, as Dr. Anuj was saying, for the lip, for the commissure? Why do we there prefer brachy over surgery?
because in surgery might cause functional problems. It is as opposed to the tongue, like you said, this lip is more fixed, and it's also a surface tumor, ma'am.
Surface tumor. Okay, the first point is correct. The surgery is morbid, and that is why it's very, very difficult to reconstruct the commissure, a competent
Hmm.
commissure. So that is why in those cases, similarly for the lip, a spreading lesion, if we excise it all, it's more morbid, the surgery. So in those cases, we can consider doing the brachytherapy. How do you
Okay.
choose a candidate for brachytherapy? What all points you consider? Apart from the site we just discussed. Any size criteria?
T1, T2 lesions.
Okay, up to 3 centimeter,
Yeah.
they say. Yeah. So that's the size
But the
criteria. Should not
T2,
be deeply
yeah,
infiltrated. Should not be very deeply infiltrative. Away from the bone, it should be. It should not be in the close proximity to the GBS, upper or lower. And in those
Okay.
cases, consider brachytherapy.
Okay.
So after the surgery, what next? Arvind sir, do you want to ask any questions?
No, I just wanted to know why do you want to address, say, level 5 also? Like 1 to 5, you said for. No, I just wanted to ask you that.
Presence of metastasis in level 2 is associated with more number of metastasis in level 5 in the especially in the prospective study that was done in our institution, including 570 patients, around 570 patients. There was an association with a
583, yeah?
positive 583.
Yeah, okay.
There
No,
was
but
an
what was
association.
the percentage?
I don't remember, sir.
Okay, then the other thing is that, is there evidence to suggest that you can do a selective neck dissection in presence of an N+ neck also?
Sir, there are no such randomized control trials, but there's a recent meta-analysis that was done by Liang et al., in which they have considered 5 studies in which they have on around 400 patients, in which they have concluded that selective neck dissection followed by adjuvant therapy is as good as comprehensive neck dissection, even in the presence of even in a N+ neck, but um, the tumor at the T stage and the N stage will have to be kept in consideration when doing the selective neck dissection.
Any particular criteria in which, even though it's an N+, you'll surely, or what are those favorable subsets in which you would consider selective neck dissection in an N+ neck? If at all, you're right, there is some vague evidences only. There is some prospective
Yes.
studies in the last 2 decades. So
Yes, sir.
in regular practice, what type of N+ necks would be suitable for a selective neck dissection, if at all you want to consider? Of course, telling comprehensive neck dissection is always a safer bet, no? In an N+
Yes,
neck.
sir.
But
Sir,
if at all you are wanting to tell SND for a N+ neck, what would criteria?
Sir, an N1 neck with a one level 1B node.
Yeah. Size criteria? Yeah, anyway, you said that. Correct.
Yes.
Okay, go ahead. Yeah, go ahead. And also about the sort of, any other classification, of glossectomies?
Sir, classification for?
Glossectomies.
So there is Ansarin et al. Classification for glossectomy, sir.
Correct,
Uh,
correct. So you're aware of
in
that classification, right? So
Yes, sir.
can
Yes,
you
sir.
sort of, tell what type of glossectomy would this be? It's always better that, sometimes when you know certain things, to sort of,
Yes, sir.
inform the examiners also. So,
Yes,
so
sir.
you're
This
aware of the publication of Ansarin's classification, when did it come? And then who
2000.
endorsed it?
2019, sir.
And it was endorsed by,
I don't know, sir.
so even the Americans also, HNS also endorsed the sort of classification. And are you, so anyway, you can read about the classification, everybody, but what type of classification of answering would this fit into for this particular patient?
This would be a type 2 or a partial glossectomy, sir.
Right. Okay, anyway, read about the answering
Yes,
classification.
yes, sir.
and
Yes.
on everybody else. Yeah, over to you. Anybody else can ask questions.
So what after the surgery, Rukmini? So you have done a tongue wide excision and a local flap. Which local flap will you consider in this case?
This patient's like we have to give the patient the options, ma'am. This patient's buccal mucosa was healthy with no submucous fibrosis. So in this patient, we could also consider a facial artery myomucosal flap. But the other option would be a nasolabial, an islanded nasolabial or a melolabial flap if the patient is counseled and is willing for a facial scar. So those two options, ma'am. Or we could also consider a submental flap, but it's an N plus neck, so we would better prefer the islanded nasolabial flap, ma'am.
Okay, before you go to reconstruction, we'll go to reconstruction. First, you tell me what would you do a tumor-directed wide excision or would you do a compartment resection in this case?
In this case, I would do a tumor-directed wide excision, ma'am.
Why not compartment resection?
A compartmental resection would, as per Calabrese et al., would entail excision of the entire compartment from the lingual septum till the periosteum and excision of all the detachment of all the muscular attachments, which is not necessary in this case, ma'am.
So, but what is the problem if I do it? So it has associated morbidity.
Yes,
and the
we could
requirement of the reconstruction can change.
Yes, yes, ma'am.
In what cases would you do the compartment resection, surely?
In more advanced diseases, man, in T3 to which is going till the midline.
Okay. And in early lesions, when would you consider?
Um, in early lesions, we
if-
would do a tumor-directed wide excision, ma'am.
That I understood, but would you consider in certain cases, suppose the lesion is deeply infiltrative in the floor of mouth?
Okay, but okay, ma'am.
It can be T1, T2 still, and if it is,
Yes, ma'am. Yes,
but
ma'am.
still you may want to do a compartment resection in those
Yes.
cases.
Yes, ma'am. Yes,
Yeah.
ma'am.
Or if even if it's a early lesion, but the sublingual space is involved.
Then also we would do a compartmental resection.
Yeah, if it's very close to the neurovascular bundle.
Then also, yes, ma'am.
Yeah, so T3, T4, of course, we all will do. There's no doubt about it.
Yes.
Okay. Then you were talking about the options of reconstruction. You said FAM flap, you said melolabial, and you said submental. Submental, you were a little hesitant because you thought it could compromise the oncologic safety as it's a node positive neck. So that
Yes.
leaves us with options of FAM flap and the melolabial flap. Tell me the advantages and disadvantages of both.
Melolabial flap, the advantages is we can get a good size of the flap, but the disadvantage is that it leaves a facial scar, ma'am. And the FAM flap, if there is no submucous fibrosis and the buccal mucosa is good, we will get and the artery and vena preserved, we will get a good surface area for the reconstruction of the defect. But it compromises the buccal mucosa and might lead to a reduced mouth opening and post healing a reduced mouth opening for the patient later on, ma'am.
So is there any size consideration or you will take out whole of the buccal mucosa? If you're talking about the trismus and all that, it's a serious issue, then you should not be doing it at all. So if you go too posterior, obviously you will land up with a trismus. But if you are just basing it anteriorly around the vessel, it may not always end up with a trismus. So you cannot take a very large, it would be 2 to 2.5 centimeters. So it is ideal for the smaller defects.
Yes.
And apart from the facial scar, what can be the other morbidity associated with the islanded nasolabial? So if you don't mark it properly, you can have ectropion, you can have deviation of the angle.
The angle,
That
yes.
asymmetry is not acceptable. So
Yes, ma'am.
it may not be very suitable in young patients. In the older
Yes.
patients, it may be a more ideal flap.
Yes, ma'am.
And if you don't have the option of the local flap, in those cases, you will go for a free
Free
flap.
flap, ma'am. Like a free radial artery forearm flap, ma'am. In this case.
Yeah. Then, now suppose you have sent this case, obviously you will be sending this case for pathology, and the histopathology shows a tumor which is 2.5 into 1.5 into 1.1 centimeter. It is moderately
ma'am.
differentiated squamous cell carcinoma. And there is no LVE, there is no PNI. Single node is positive, and there is a microscopic ENE, which is less than 1 or 2 millimeter. Now, what will you do in this case?
And the patient for adjuvant RT, ma'am.
Just tell me the P stage for this patient.
And PN2A.
You jump to N only. What happened to T?
T, T2,
Two-
ma'am.
2.5 into 1.5 into DOI of 11 millimeter, 1.1 centimeter.
Oh, T3, ma'am.
And N becomes?
N2A.
There is ENE.
One node with ENE.
Where it goes?
N2A, ma'am. There's one node with single node less than 3 centimeters with ENE. So pathologically N2A.
Okay. So now that prognostic stage grouping becomes?
Stage 3, ma'am. Stage 4A.
So you have to be very, very careful with the staging.
Yes,
It
ma'am.
looks
Yes,
very
ma'am.
simple, but then you should do it. Okay. Now tell me what adjuvant treatment would you offer to this patient? So it is a T3 and N2A, it becomes stage 4. What adjuvant treatment would you offer to this patient?
Adjuvant CTRT, ma'am.
Why CTRT?
Because there is extranodal extension, ma'am.
Is there any way you can classify extranodal extension?
Less than 3 mm and more than 3 mm, sir.
3 or
Micro and
1 or 2 mm.
Why 3?
2.
Whose paper? Which paper?
What is microscopic and macroscopic ENE, Rukmini?
Less than 2 mm and more than 2 mm, sir.
Is there any implication on the treatment?
Would consider the patient for adjoint CTRT with the presence of ENE, sir.
Then why classify as minor and major then? If you're giving CTRT for,
Okay.
I mean, still we don't know the answer, but is there any evidence to say that you can avoid CT, the chemotherapy in minor ENE?
I don't know, sir. I've not read, sir.
Check. I think there is some literature
Yes, sir.
available
Yes.
on that. Okay.
Yes, sir.
Dr. Rukmini, does the presence or absence of ENA, major or minor, have an implication on the dose of radiation delivered? Are you aware?
No, sir.
So what you're trying to tell us is that you need to do chemoradiation. That's
Yes,
just
sir.
one way of saying you want to intensify treatment. So
Yes,
only
sir.
radiation is not enough. Are you
Yes,
aware
sir.
of any other means of intensification of radiation?
Mhm.
Are you aware
I
of
didn't.
the use of altered
Radiation.
fractionation schedules?
Yes, sir.
Do you have any evidence that it works in the postoperative setting in the oral cavity?
Sir, in our paper of adjuvant treatment in oral cavity in the OCAT trial on 900 patients, in which we compared between only RT, CT, RT, and accelerated fractionation, there was no difference in the overall survival between the three groups, sir. So,
Are you aware of anything else that has been done in this regard? Any meta-analysis of studies which have been done?
no, sir. I have not read. Sir.
Would you recommend altered fractionation in any patient?
No, sir.
Any other form of intensification of radiation apart from chemo, the use of chemo in this adjuvant setting? Are you aware of cetuximab as a concurrent agent?
Yes, sir.
Do you have any evidence regarding the use of cetuximab in the adjuvant setting concurrently with radiotherapy?
So in the Bonner trial, they included cetuximab as a adjuvant along with radiation, sir.
Any prospective studies that have been done in this regard or ongoing studies?
I don't know, sir.
There is currently an ongoing study regarding this. You can look it up.
Okay, sir.
Rukmini,
Yes, sir.
if for this patient, if it comes out to be a T2N0 moderately differentiated cancer,
Yes, sir.
so in what indications will you give adjuvant RT alone? Like in early oral cancers, like what
Yes,
is
sir.
the indication of giving adjuvant RT? Can you tell some indications and when will you consider?
So some adverse prognostic factors like uh, poorly differentiated tumors with the presence of perineural invasion, worst pattern of invasion type 5, presence of tumor budding.
So you told about degree of differentiation. So poorly differentiated tumors, which are more aggressive, that is one. Then
Yes, sir.
other than that, perineural invasion. Do you know how is perineural invasion quantified?
According to the Brandwein and Gensler classification, the tumor around small nerves less than 1 mm is it is around small nerves less than 1 mm and more than 1 mm, sir. So, like large named nerves and more than 1 mm is the second classification, sir.
Okay. Other than that, what are the other adverse features? So
Worst
one is
pattern of invasion.
differentiation. Yeah, and in
Worst
what other
pattern of
indications will you give RT? If I just wanted to ask you, other than perineural invasion, lymphovascular emboli, WPOA5, what are the other considerations? Is margin a consideration that you will give for giving adjuvant RT?
If there are close or positive margins, we will give adjuvant CT-RT, sir, not RT alone.
Close margin, how do you define close versus positive margin then? And do you give adjuvant CT-RT for all patients with close margins?
Yes, sir.
What does the evidence suggest? So as per the Bernier and the Cooper trial, which we were talking about, EORTC
Yes,
and
sir.
RTC. So is
Yes,
it
sir.
for the close margins as well as positive margins, or
It is for
is it for
positive
positive
margin.
margins?
It is for
Because
positive margin.
yeah. So ideally in close margins, which is from 2 to 5 millimeter, we still
Can give.
can give adjuvant RT maybe to a slightly higher dose than what we do routinely. Up to about 64 grade, we can go and treat,
Okay.
but not adjuvant CTRT is not offered in all cases with close margins. Okay, with positive
Okay.
margins, what you told is correct.
Okay, sir.
And if it is an N1 disease,
Yes, sir.
so if it is a T2 N1 disease, then what will your stage be? And will you recommend adjuvant RT or observation? If it is a single node positive without ENE and the focus is very small, like maybe 2 millimeter or so, will you send the patient for adjuvant RT or will you observe? No other risk factors are there.
If there's a node positive, then it becomes N3, sir. So I would send the patient for adjuvant RT, sir.
Because it is stage 3, because this is have you read the ASCO recommendations for a patient with a single node positive? What does the ASCO recommend in such a setting without any adverse features and with a single node positive? So the data is mainly from the NCDB and the SEER database. We don't have any level 1 evidence for this, but yeah, like
Okay,
you told, it is stage 3 if it is a node positive patient.
yes, sir.
But in the absence of any other adverse features, and if it is a very small focus, there are clinicians who may observe, but right now we don't have evidence to suggest that. So if it is a stage 3, we go ahead with adjuvant RT.
Okay, sir.
Rukmini, are you aware of any histological risk assessment models in early stage oral cavity cancer?
So the Brandwein and Gensler histological risk assessment, sir.
Can you tell us a little bit about that?
So Brandwein and Gensler has three things that they take into consideration, sir. Uh, the pattern of invasion, the lymphocytic host response, and the presence of perineural invasion. So in the patterns of invasion, there are 5 types. In type 1, it is the tumor, the pattern of invasion is the tumor, the broad pushing surface. And in type 2, it is finger-like projections. In type 3, it is islets of cells which are invading into the normal tissue with less than 15 cells. And type 4 is um, smaller islands of less than 15 cells which are invading. And type 5 is tumor satellites which are present at a distance of more than 1 millimeters from the tumor. So that was pattern of invasion. And then they also check the lymphocytic host response, which are categorized into 3. In type 1, there is a dense rim of the lymphocytic response. And in type 2, there is um, more lymphocytic response, whereas in type 3, there is no host reaction. And perineural invasion is divided into 2 small and large nerves. Perineural invasion less than 1 mm and more than 1 mm. Sir.
Great. And could you also tell us why depth has been included in the recent AJCC modification as an important prognostic factor in staging?
Sir, in the database from the International Consortium of Outcomes Research in which they have analyzed around 3,900 patients, they have seen that depth of invasion has an important role in the prognosis with an impact on the presence of neck nodal recurrences, neck nodal metastasis.
So what are those levels of invasion that are important? The depths that have been mentioned by them in T1 and T2, right? So in
Yes, sir.
T1, the depth, and the T2, the depth that they think are important for this.
Less than 5 mm and 5 to 10 mm. Sir.
Based on that, would you then recommend radiation for somebody who has a depth of invasion more than 5 millimeters?
So, no, sir.
Rukmini, the study you
Yeah.
quoted is the ICOS study, right?
Yes, sir.
In that, when they compared between depth of invasion less than 5, 5 to 10, and more than 10, it was saying that DOI alone is not an indication for port without any other adverse features. So if there is a combination of features, then it is different. But actually in that study, which you quoted, it was shown that there was no difference in the primary endpoint between the three groups. So like depth of
Okay, sir.
invasion also, when you see like if it is more than 10 millimeter, okay, it's a T3 you can give. But this is not the actual study that you should have quoted for this being considered as a risk factor.
Okay, sir.
Rukmini, there is a
I-
study to show that 5 millimeters and above does not really make a difference as far as the outcome of adjuvant radiation is concerned. So do not mention that as a criteria ever. You can
Okay,
use
sir.
it as a soft risk factor in combination, as Dr. Anuj rightly pointed out.
Yes,
In
sir.
combination with other negative prognostic factors, you could then recommend it. But as a
Yes, sir.
standalone factor, it does not make any difference.
Yes.
One more thing, do you
Yes.
routinely do frozen sections in your surgeries?
Yes, sir.
What if a
It's-
patient was positive on frozen section and then you achieve negative margins? Would you then consider that to be a negative prognostic factor?
Sir, initially, R plus resection, which after re-resection becomes R0, it's not the same as in initial R0, sir.
So is there any evidence that the radiotherapy use is associated with a benefit in this subset of patients?
Mm. The paper by Mustafa Bulbul, sir.
Correct. So
Mm.
there is evidence that that might also become a soft risk factor for addition of radiation,
Yes, sir.
along with other factors as well.
Yes, sir.
That's a meta-analysis, no? Bulbul's
Yes, sir.
meta-analysis.
Yes, sir.
Good. Chalo, I think we can
Okay.
call it a day, I think.
Any other questions?
Not from my side.
None from my side also.
And none from my side as well.
Dr. Komal?
Yeah, thank you so much, everyone. Thank you, Arvind sir. Thank you, Dr. Richa. Thank you, Dr. Anuj. Thank you, Dr. Amita, for such an elaborate discussion. And I would request all of you to give marks out of 10 for Rukmini. Like how she performed out of 10. Arvind sir, please, if you can start.
Yeah, maybe. No, she performed very well. I don't know marks and all those things, maybe, but definitely she did very well. I think more than 75%.
Okay, sir.
I mean, that's because we are sometimes we don't sort of we encourage people to have some sort of room for improvement. But she did very well. I think that's what my impression was. Yeah.
Yeah, I think she qualifies for the gold medal exam. So 75% is honors. And now you come back for a more difficult exam where you get a gold medal. So that's how I would put it.
Yeah. 7 out of 10 at least.
Okay, so Rukmini very well performed, as everybody is saying. And with this, we'll wrap this session. Thank you, everyone. Thank you to all the participants. We'll be back after 15 days with another topic and another set of examiners and students presenting. Thank you, everyone. We have these videos available on our YouTube channel. The link is available in the chat box. So subscribe to our channel. Thank you so much.
Thank you. Thank you, Komal Azim. Thank you. Bye-bye.
Good evening, everyone.